Hello and welcome. My name is Joseph Ceramelli. I oversee grand rounds for the Department of Psychiatry and Behavioral Sciences, and thank you for joining today's grand rounds presentation. So some points about the grand rounds series. For this academic year, we've developed a theme called Next Steps in Care Include, which is an effort to have a series of presentations on innovations and updates in clinical care. There's a group of us who work consistently on the Grand Round series. With me as the faculty lead, Samhar doing the coordination and communications, and Mike Walker as well on technology. We have the presentations archived on the Grand Rounds website, and the funding for the presentation is through the Ripley Fund in the department and some institutes and centers in the department, such as the Garvey Institute. We have a Grand Round speaker evaluation form that I'll put the link of inside the comment box today towards the end of the presentation. Also, I'd like to encourage you to fill out the evaluation even before the discussion part at the end ends. I can use those points to inform next steps in the Grand Round series. So now I'd like to turn it over to Dr. John Neumeier to introduce today's speaker, Dr. Angela Fang.
Thank you, Joe. We are very fortunate today to have Dr. Fang speak to us. She received her bachelor's degree from Dartmouth and then her PhD in psychology from Boston University. And then she completed her clinical internship and her postdoctoral fellowship at Massachusetts General Hospital in 2016. She became assistant professor at Harvard, but the UW Department of Psychology was successful in recruiting her to join the university last year. She's currently the recipient of a K-23 Career Award from the National Institute of Mental Health. She recently received a NARSAT award from the Brain and Behavior Research Foundation, and she's had other funding as well. Currently, Dr. Fang is the assistant professor and director of the Center of Neuroscience, Neuroendocrinology, and Clinical Translation, the CONNECT Lab, in the Department of Psychology. Her work aims to translate findings from basic science to inform clinical applications. She's also a licensed clinical psychologist and co-directs the CALM Clinic for anxiety, trauma, and obsessive compulsive disorder within the General Training Clinic in the Department of Psychology. In addition, I'll add how excited I am to have Dr. Fang as a colleague who has already been reaching out and forming collaborations with our department's faculty. Her integration of clinical expertise, circuit and neurochemical neurobiology, and treatment development represents an exciting translational opportunity. I would like you to join me in welcoming her to the university and as today's Grand Rounds presenter. Thank you, Angela.
Thank you so much for that lovely introduction, John. Can you hear me okay?
Yes.
Great. Yeah, thank you so much, John. That was, you were one of the first people who welcomed me to the department when I moved here, and I hadn't ever been to Seattle prior to my interview. So I'm really delighted to share more about my work today and get to know all of you better. So today I'll be talking about leveraging predictive brain imaging and intranasal oxytocin to deliver precision treatment for anxiety and obsessive compulsive disorders. And just a statement first to say that I don't have any financial disclosures. So I wanted to start off the talk today setting kind of a humble context for the real world clinical challenges that we face in psychiatry. So I had worked previously in a department of psychiatry for many years at Mass General Hospital, and I surveyed our clinicians, specifically in the OCD and related disorders program, to see what they perceived as the greatest clinical challenges. And you could see how they lumped together in access challenges, assessment challenges, and treatment challenges. And we don't have to go through all of these to really acknowledge just the extent of room there is for improvement, despite having really strong evidence base for psychological and pharmacological treatments for psychiatric disorders. I think one of the greatest challenges in our field is that even our first line interventions leave a lot of folks still very symptomatic. So most studies, most randomized clinical trials define treatment response in terms of just showing some reduction of symptoms by post-treatment, but we're actually really interested in remission, right? As clinicians, we really want our patients to show high end state functioning at the end of treatment, not just some percentage reduction of symptoms. So when we use the definition of remission here, there was a recent meta-analysis that included 52 studies of anxiety and obsessive compulsive disorders, showing that still more than half of folks enrolled in these studies are not meeting remission criteria. So just really underscoring how even our first line interventions like CBT for anxiety are leaving so many people still really symptomatic. So I think this reflects a huge gap because we actually have really strong tools at our disposal in psychology and neuroscience and good understanding of the mechanisms underlying these disorders, but they're somehow not getting translated into the clinic. And there's also another gap, I think, in terms of extrapolating from group-based studies to apply knowledge from those studies to that N of one who's coming into your clinic with really an idiosyncratic presentation, different social cultural context, and trying to figure out based on the evidence what the best treatment that we should refer them to. And that's another huge challenge in our field. So the first half of the talk, I'll share some work I've been doing on predictive brain imaging as one attempt to try to reduce this gap. Here we're trying to scan folks using an MRI scanner at pre-treatment when they come into the clinic to try to predict something about how they're going to respond to a given treatment. So in my case, it's giving everyone cognitive behavioral therapy for anxiety. I'll also share in the second half of the talk some findings on novel therapeutics as one way to try to bridge this translational gap and improve treatment outcome for patients with anxiety and OC disorders. So I started off in a lab in graduate school that was interested in testing the efficacy of a pharmacologic agent called D-cycloserine. And DCS is actually an antibiotic for tuberculosis, but also is a partial agonist of the NMDA receptor site, and has been shown to speed up the rate of extinction learning and memory consolidation in anxiety disorders. So it was a really natural next step for us to be thinking about other agents that might have modulatory effects on basic social learning processes, such as oxytocin. And so that work started off in graduate school, and I'll share some of those findings. So when I was thinking about predictive brain imaging and what would be a construct that would predict treatment response, I relied heavily on my clinical observations of treating folks with anxiety and OC disorders. And I was very interested in something called self-focused attention. And I think the best example I've given, that I tell a story often of self-focused attention as being exemplified by this one patient I saw, one of the first patients I saw with BDD. On the way out of the door to do our first in-session exposure, he was so self-focused that he actually walked right into a wall sconce because he wasn't looking around him. And I think that reflects just the real nature of self-focused attention. When you're so turned inward, you're reflecting excessively on your thoughts, feelings, beliefs, your physical states. You're just not able to attend to the external environment. And that's really detrimental for a learning-based treatment like exposure therapy, where you're being asked to confront your fears, but also integrate new learning and disconfirm your previously held negative beliefs about the feared stimulus. So the general hypothesis that emerged was that self-focused attention can predict poor treatment response. And I was interested in whether we can identify the neural correlates of this construct and whether that would be maybe a more sensitive predictor of treatment response than our available clinical measures. So self-focused attention is really this construct that falls on a spectrum. It's not always bad. So on the adaptive end, it can promote self-knowledge and problem solving. And this is when it can be done flexibly, that you can reflect on yourself in a flexible way. But on the other end, it's maladaptive if it disrupts awareness of external content. So here, self-focused attention can be a bad thing if it's excessive, sustained, or rigid. But in general, we're talking about a cognitive style that involves just preferential attention to the internal milieu. And I think most people, when they think about self-focused attention, they think about depression. And so those who know David Foster Wallace, who's a famous author who suffered from depression, he wrote a story about a depressed person. And this woman, he tells in the story, was so consumed by her depression, her self-focused attention, that when she discovered that her therapist had died by suicide, she was still so reflective about what that meant for herself, for her loss, her abandonment, her grief, her trauma and pain and affective survival. And it speaks to that well-known self-rumination kind of characteristic of depression. But actually, it's really common across anxiety and OC disorders as well. So that's something I definitely observed clinically and studied in patients with social anxiety disorder and body dysmorphic disorder. So I've been very interested in the overlap between these two disorders because they're really bound by a core fear of being negatively evaluated by others for slightly different reasons, but it results in so much social avoidance across these two disorders. Upon looking at them on paper, they may not seem to be similar because they're actually now separated into different categories in the DSM-5, but they actually share this core fear. They have heightened self-focused attention and other cognitive biases. They have high rejection sensitivity, strong patterns of social avoidance that I've mentioned as a result of that fear of being evaluated by others. They both preferentially respond to CBT and SSRI medications and have high patterns of comorbidity. So I've been the focus of my talk today will be on these two disorders. So as I mentioned, the disorders categorized, the disorders in green are categorized along an anxiety spectrum now in DSM-5, which is separate from the disorders in blue, which are OCD and BDD, which are now put into a separate obsessive compulsive spectrum in DSM-5. But I would argue that they're all actually functionally linked in the same way, in the sense that the avoidance that's so characteristic of these disorders are driven by negative reinforcement to try to mitigate some fear. So I see them as all falling on the same kind of fear-driven spectrum. And I would say that self-focused attention also falls along this spectrum, is a dimension that cuts across all of these disorders as well. And so what we're talking about is really a dimensional approach to classification that was really articulated by the research domain criteria at the National Institutes of Health. So here, the idea is that you take folks who cut across multiple disorder categories like major depressive disorder, mild depression, bipolar depression, and we assess them across multiple levels of analysis like genetic risk, brain activity, physiology, behavior, and life experience. Of these, we typically in clinical practice really only rely on clinical interview to assess life experience, maybe behavior through neuropsychological tasks or well-validated paradigms, but we really are not systematically assessing genetic risk, brain activity, or physiology right now upon intake. So what if we did and integrated all of this data and derived more meaningful categories that cluster people together based on shared etiological mechanisms? Then we might be able to actually target interventions or develop interventions that more accurately target those mechanisms. And this would be a new way of thinking about classification of these anxiety disorders. So when thinking about where would self-focused attention be represented neurally, it was really natural to think about the default mode network. This is a network that has been shown to support internal cognition. And it was actually discovered a little bit on accident. So it was discovered by several studies that showed across different types of tasks used in fMRI studies that there were two regions of the brain that would show reliable decreases in activation. So these are the medial prefrontal cortex and the posterior cingulate cortex shown in the arrows. And it turns out if you take the low frequency bold fluctuations from these two brain regions at rest, turns out they seem to be temporally synced so that they seem to be communicating with one another in real time. So if you were to map out the resting state network from these two regions and compare them to these task-related decreases you see in the activation map above, they show remarkable overlap. And what does this all mean then? Well, it means that the DMN actually is a network that needs to be suppressed during a task that requires external attention demands. So when you're engaged in a task, you need to suppress your DMN, and then it comes online only when you're supposedly at rest or not engaged in some focused external self-focused task. So it kind of works like a screensaver, because the screensaver comes on only when you're not engaged in some task in Microsoft Word or PowerPoint, and it shuts off when you're ready to use one of those programs, when you're actively engaged in some external task. So I thought this was a nice analogy for the default mode network, just to understand that it actually does inherently compete with other resting state networks, depending on whatever task you're performing. And so I'd like to show you what some of these other networks are, that the default mode network has to interact with many other resting state networks in order to process social information properly. So this includes the executive control network, the salience network, dorsal attention network, auditory network, sensory motor, and visual. And there is this inherent competition, sometimes represented by what people call anti-correlations between the default mode network and what people call these task positive networks. So it's sometimes, the default mode network is sometimes called a task negative network because of that inherent antagonism between these networks. And studies have shown that there's disruptions in the default mode network, both within and between the default mode network and these other networks in anxiety and obsessive compulsive disorders, but no one has specifically linked this to self-focused attention. And so we were really interested in whether self-focused attention can explain some of these disruptions. So we predicted that people with self-focused attention might show rigid DMN activity, meaning that they might not show flexible deployment or turning on and off of the DMN when they should, or they might just show heightened DMN activation, or they might show sustained DMN activation in the sense that activation is persisting in subsequent trials when they're supposed to be focusing on something non-internally related, something externally focused. And it turns out there's actually many studies now that have identified regions within the default mode network as predicting treatment response to either CBT or medications in anxiety and obsessive compulsive disorders. So this is a really crude drawing showing all of the brain regions that have been reported in the literature for anxiety and OC disorders, with the ones in green being anatomical components of the default mode network. Just to show that some of these studies point to the default mode network already. We just don't know clearly yet if they're linked to self-focused attention. So what we did in the study was we used resting state functional connectivity to identify the neural correlates of self-focused attention in patients with BDD and social anxiety. So we took a real dimensional approach. We didn't just take, people who met criteria for social anxiety and BDD and compare them to controls. We actually recruited and sampled our study based on showing heightened levels of self-focused attention. So our patients needed to score 1 standard deviation higher on a self-reported measure of self-focused attention, whereas our controls had to show 1 standard deviation scores below a normative mean on that same measure. And so we were comparing patients and controls in that way, and drew patients from the social anxiety and BDD populations who met that cutoff score. And so using that kind of sampling approach, we scanned everyone prior to 12 weeks of cognitive behavior therapy And to identify the default mode network, we used a seed to voxel approach shown here. So we took a seed region in the posterior cingulate cortex, which is shown in red. And this is a core hub region of the default mode network that's often used to identify the DMN. We took the average time series of the seed and looked at correlations with every other gray matter voxel in the brain for each individual subject and derived connectivity maps for each individual subject, Z-scored them so that they could be compared across subjects using Fisher-Z transformation. And that allowed us to derive group level maps that could be then compared. And our hypothesis was that people with heightened self-focused attention would show excessive within DMN network connectivity, which is unfortunately not supported. It turned out that there was no group difference between the patients and controls within the DMN. What we found instead were several clusters showing abnormal connectivity with the seed outside of the DMN. And several of these regions fell into what we consider to be task positive networks. So I'm showing here a plot for connectivity between the PCC seed and a cluster in the right superior parietal lobule, which is part of the dorsal attention network. And we know the DMN and the DAN are inherently anti-correlated, typically at rest, because the default the DMN mediates internal attention and the DAN mediates more externally focused attention. So this connectivity at pre-treatment showed significant group differences between patients and controls. And you can see here the distribution separately for the patients and controls, with patients showing reduced connectivity between the PCC and SPL and controls showing slightly positive connectivity. And the green and red symbols just represent the separate distributions for social anxiety and BDD, just to show that there's really overlap with these two disorders. It's not that the connectivity values separate the two disorders. So this was interesting and suggests that connectivity between the PCC and SPL at baseline could represent potentially neural correlates, resting state neural correlates of self-focused attention. And I'll also say what was convincing was that this connectivity at baseline was significantly associated with self-reported self-focused attention. And it did not show significant associations with related measures of rumination or depressive severity or BDD or social anxiety symptom severity. So there seems to be some specificity here in terms of what this connectivity is tapping into. And we believe it's tapping into this DMN, DAN abnormality that is reflecting an inability of these patients to toggle between internal and external attention environments. So we sought out to find a neural correlate that is represented within the DMN, but instead we found something that was really represented by abnormal interactions between the DMN and other networks. So just to show some of the prediction results, I wanted to start off with just showing the individual trajectories for some of the patients in our study. So I was the sole therapist for this open trial. I provided everyone with 12 weeks of CBT, which were off-the-shelf treatments. And I treated 15 folks with primary social anxiety disorder and 15 with primary BDD. And so their respective clinician-rated measures are shown here on the left and right. And they were assessed by an independent evaluator. So I was the therapist and this was someone else who did the assessments. And overall, people improved about 50% across these 12 weeks, which is pretty on par with meta-analyses of the effects of CBT for these disorders after 12 weeks, with some variability in treatment response, which we defined as at least a 30% symptom reduction by post-treatment. And what we found again here is that baseline DMN connectivity predicted response to treatment to CBT. So there were several brain regions that were shown to be associated with treatment response, defined as a % of symptom reduction between pre to post treatment. including a cluster in the SPL, which overlapped with the finding I just mentioned. And here I'm plotting to show you that the connectivity against symptom reduction, to show that those who started off treatment with intact PCC SPL connectivity, approaching the level of healthy controls from the finding I just showed you, they reflect people who have more intact self-focused attention, and they did the best in treatment. They achieved the most symptom reduction after the 12 weeks compared to folks who had weaker connectivity at baseline. So this is accounting for about 40% of the variance in treatment outcome, and provides some preliminary evidence that this marker of PCC SPL connectivity at pre-treatment really might be a meaningful marker of self-focused attention that predicts response to CBT after 12 weeks. So our clinical goal for this is to eventually use some of these resting state markers, potentially for DMN dysfunction, as some way of predicting response to treatment. And ideally, we have a neural marker at baseline that could distinguish responders and non-responders to treatment, so that you can actually know that, hey, treatment A is really not going to be an effective start for this person. Why don't we try them for treatment B first? Because I think that's always the clinical decision that we're making in the real world. So most of the studies that have been done on predictive brain imaging and anxiety and OC disorders have relied on these small open trial studies, like what I did in my K award and the findings I just showed you. And the problem with that is that those open trial designs don't tell you whether the treatment response effect you're seeing is really attributable to the treatment. And it's possible that our patients would have improved anyway in their symptoms during that 12-week time, or there's no control for another treatment. And so what we're really after to continue this line of work is to show treatment specificity or prediction specificity for some of these baseline neural markers. So I want to switch gears a little bit now and tell you a little bit about my oxytocin work. And I'm going to start with a neurobiology lesson, because oxytocin is a fascinating drug. And I don't know that everyone appreciates how there's such a diverse repertoire of its behavioral effects and its peripheral effects. And just, I think telling the story of its release mechanisms can help help us understand that. So oxytocin is produced in specialized cells of the hypothalamus, and we generally know about its endocrine functions as a hormone. And so once it's produced in these specialized cells, it's released through the posterior pituitary into the periphery, and it exerts actions on uterine tissue and breast tissue, and that's what gives rise to oxytocin's endocrine effects in terms of milk letdown, lactation. It helps induce uterine contractions during labor. So those are really well-known functions of oxytocin that have been well studied. But oxytocin also has functions more like a traditional neurotransmitter and has synaptic transmission, because once it's produced in the specialized cells of the hypothalamus, it also has long-range projections from the hypothalamus everywhere in the cortex. So oxytocin can be transmitted through this type of synaptic signaling, just like traditional neurotransmitters. And that's what gives rise to its effects behaviorally through the central nervous system. So its effects on social and emotional processing and things of that nature. So that's really fast transmission. But oxytocin also can be released dendritically, and this is known as paracrine release. So this means that oxytocin can be slowly diffused into the circulating CSF in the brain. And we believe this is why it has such a long half-life in the brain when it's given exogenously through the nasal cavities. So there's slow diffusion, and this gives rise to some of the local physiologic actions of oxytocin, and really contrasts with its half-life in the blood, actually, which is only 6 minutes. We believe after exogenous administration of oxytocin, it could stay in the CSF in elevated levels up to 90 minutes. So all of these release mechanisms, I think, tell a story of oxytocin being a really diverse, having really diverse effects, physiologic effects, both in the central nervous system and peripherally. And there's quite a bit of debate about the extent to which the central actions and peripheral actions are correlated. But there's quite a literature that's been developed since the discovery of intranasal delivery of oxytocin that oxytocin has therapeutic potential. And these are some of the studies supporting that in both healthy and clinical populations. The oxytocin buffers responses to social stress, improves emotion recognition, reduces attention bias to emotional cues. For anxiety disorders, it's been particularly relevant. That's been shown to dampen amygdala reactivity, at least not in both men and women. We could talk more about that in the Q&A. It facilitates extinction recall, and also a study that's shown that it blurs self-other processing, which may have potential indications for reducing self-focused attention in this population. So I want to tell you a little bit about some studies that I've done looking at oxytocin in the pathophysiology of body dysmorphic disorder. People generally tend to not know too much about BDD, at least in general psychiatry. It tends to be overlooked as a psychiatric disorder, but it's been shown to be very similar to OCD, which is why they're linked together in the DSM-5. So they have a similar prevalence, 1 to 3% lifetime prevalence in the general population. It onsets in late adolescence, approximately equal gender ratio. Everyone thinks about their appearance, but these folks think about their appearance up to 3 to 8 hours a day. And the core feature is being fixated on perceived flaws in their appearance. So to outside observers, you would never be able to tell someone with BDD from someone without BDD because it's not observable what their perceived flaws are. So there's a real dysmorphic element and distorted body image element to this condition. And as I mentioned, social avoidance is really prominent, which is why it motivated a study to look at what is the underlying pathophysiology of BDD in terms of endocrine contributions. So we sought to test whether people with BDD showed deficient levels of endogenous oxytocin and whether that could serve as a biomarker of social cognitive impairments in this population. So a task that's often used in conjunction with oxytocin is the reading the mind in the eyes task, which is shown here on the right, that you're given a series of stimuli of facial expressions from the eye region, and you're asked to infer what the emotion is. And this is a pretty complex emotion recognition task, but we wanted to know whether people with BDD performed worse on this task and whether oxytocin could be a biomarker of that impairment. And this is me doing bench work, which we typically don't do as clinical psychologists, but I was so intrigued by our protocol. We actually sampled we used a frequent sampling protocol for this and drew blood, fasting levels of oxytocin first thing in the morning. So participants couldn't drink or eat anything 12 hours before. And we sampled blood every 5 minutes over the course of an hour. And we instructed nurses to not engage too much with the patients during that time so as to not overly induce oxytocin release. And it was in service of ultimately looking at secretion dynamics over the course of that 1 hour because oxytocin has pulsatile characteristics. So we ended up just actually integrating all the samples because we ran out of funding for these early career studies. So I'm going to show you actually pooled data across that entire hour. But first, to show you the behavioral results across multiple tasks of emotion recognition and face memory, people with BDD did not differ in performance compared to healthy controls. In fact, on the reading the mind in the eyes task, they actually performed better. And this is in contradiction to one study that showed there are no differences in the reading the mind in the eyes task for BDD. But One explanation is that people with BDD have been shown to discern features in the face quickly. They seem to be highly skilled at discerning differences because of their attention to detail in zooming in right on specific features of people's faces. So it's possible that they would perform better on these more complex emotion recognition tasks for that reason. So in any case, then, our study was not able to identify a link between social cognitive impairments and endogenous oxytocin because there were no impairments in social cognition. And that's consistent with the literature in BDD, actually, that they seem to have fairly intact emotion recognition ability, but I'll describe in a moment specific deficits that they show. So what we found instead was that people with BDD displayed elevated serum oxytocin levels using unextracted oxytocin that we assayed using ELISA kits. And people with BDD showed heightened levels compared to controls, and this was associated significantly with their symptom severity. So we're plotting here their symptom severity on the y-axis. And this was an interesting finding because it suggests that endogenous oxytocin might actually be a better proxy of BDD severity than social cognitive impairments. And there's a couple of explanations for this. One is that we know that oxytocin plays a role in stress regulation, and these patients are really anxious and really stressed. So it could be indicating increased production of oxytocin in response to that increased stress. We did also assay cortisol, but we unfortunately did not find any associations between oxytocin and cortisol, nor any subjective measures of anxiety or stress. So there is nothing in our data to support that explanation, but that could be one. And I'll also mention that in this study, we recruited both men and women and controlled for gonadal hormones as well. So we tested for testosterone and estradiol as well and covaried that out. Another explanation is that people with BDD have such severe social avoidance that increased production of oxytocin might be used as some compensatory mechanism to help them re-engage in social situations. Again, fairly speculative explanation, no support from our data to support that, but the findings are suggesting that people with BDD are producing excess oxytocin or showing increased production of oxytocin. So I mentioned that people with BDD have a specific impairment in emotion recognition, and it's only when they think that someone is looking in their direction in a self-referent context. Otherwise, if they are led to believe someone is looking in someone else's direction, they don't show a deficit in being able to identify what the emotional expression is in terms of emotion recognition ability. So this is a face from the Ekman standardized face set that we used in another study. And this is a face that's actually displaying a neutral facial expression. But what people with BDD see is actually a face conveying anger or contempt. And so we wanted to know whether oxytocin could modulate this bias. So this was the measure that we used in the self-referent condition. They're asked to interpret what is this facial expression. So that's a measure of accuracy. And then also, why are they looking this way? Are they looking at it because of something you did, because of me, or because of the situation? So they're asked to make some sort of internal attribution or an external attribution. And we know from previous studies that people with BDD tend to make an internal attribution in the self-referent condition. That's part of their emotion recognition bias. We used a standardized intranasal administration protocol, obtained an IND application from the FDA. We used a double-blind placebo-controlled within subject design, so that subject served as their own control with a 1-week washout period. So they came back to the clinic again to receive the other drug that they didn't receive the first time. We used a dose of 24 IUs, which is the most common dose that's used in single dose studies, acute administration protocols of oxytocin. There was a whole protocol that involved them tipping their head back 45 degrees, blowing out their nose and trying to enhance nasal absorption. We began experimental tasks 45 minutes after drug administration, which coincides with what we believe to be the peak CSF effects. So we showed that, we found that in the self-referent condition, giving people with BDD oxytocin, here on BDD, the BDD group is on the right, did somewhat give them a bump in performance in terms of the number of correct trials that they achieved. And this was a significant group by drug interaction, but it's really being driven by the BDD group doing a little bit better and the healthy control group doing a little bit worse. And it actually didn't hold up in the post hoc tests. So we were initially excited by this because it was only present in the self-referent condition where we know people with BDD have the bias, but it didn't hold up in the post hoc tests. However, in the attribution data, we found in the other referent conditions that this is where patients are asked to interpret, why is this person looking in your friend's direction? They tended to show an effect when given oxytocin in terms of making more internal blame attributions of their friend. And so here on the right is the BDD group. You see that when they receive oxytocin, their attribution scores are lower. And lower scores here mean that they gave more internalizing attributions, meaning that they blamed their friends more. And this was a significant interaction that did hold up, that was a really strong effect. And we were wondering, is this somehow related to their delusionality? Because people with BDD are sometimes so delusional, not sometimes, often highly delusional and convicted about their beliefs and skeptical of others' motivations, that we wanted to look at the influence of delusionality. And indeed, we found a significant interaction between drug and delusionality. And so we plotted here on the x-axis, the Brown Assessment of Belief Scale, which is a clinician-rated measure of delusionality in this sample. And those who are most delusional, who received oxytocin, gave the lowest attribution scores compared to BDD patients who were not delusional. So all of this to suggest that oxytocin can actually worsen existing tendencies. So if your BDD patients are already skeptical of others' motives, already really severe in their symptoms, giving them oxytocin may actually just worsen those tendencies. And that's really consistent with a whole body of literature now that's emerging in clinical populations that administer intranasal oxytocin. I also conducted a variety of studies in social anxiety disorder, where we looked at its effects on social behavior, attention, and motivation. And I won't go into these findings, but we actually saw the same story, that there was never a universal effect of oxytocin for patients with social anxiety. It depended always on their symptom severity or their attachment history. So giving people oxytocin who had already a poor attachment history or really severe symptoms of social anxiety seemed to just make them worse. And it seems to be that oxytocin helps only those within a moderate range of dysfunction. I guess you could think about it like CBT as well. Just people who respond the most to your treatment need to be somewhat having intact cognitive resources in order to engage in the treatment well. They can't be so ill that they can't make use of the learning-based strategies. So it's really consistent with the findings that I saw in social anxiety. So to summarize what we found in the oxytocin research, in BDD, oxytocin might exacerbate existing attributional tendencies along individual difference dimensions like delusionality. And this really fits with the general theory of oxytocin's actions called the social salience hypothesis, that it's acting as a salience regulator. And if that salience is detecting, or if in BDD you're so attuned to detecting salience associated with social threat, for example, that's just going to get worse when you receive oxytocin. There might be subgroups of people who still respond to oxytocin, but it's not universally effective, and so we need to be really cautious before we implement it clinically. So in the final few minutes, I want to share with you some future directions of both the predictive brain imaging work and the oxytocin work, and hopefully get some time for questions at the end. So we recently submitted an R01 proposal, which is an extension of the findings that I described to you initially with DMN dysfunction. And what we propose to do in this grant is to refine an integrative model of anxiety and OC disorders that's characterized by network disruptions, particularly stemming from the default mode network. And we hypothesize that self-focused attention is one of the explanations for some of the DMN disruptions that have been reported already in literature. So the idea here is that we would assess patients across anxiety and OC disorders, not just social anxiety and BDD, but we would expand it to people with panic, with GAD, and OCD as well. And we would assess them not just using clinical interview and self-report, but potentially also blood and getting a pre-treatment scan prior to getting treatment. And the idea here is that using multimodal assessment might be more sensitive in predicting their response to a given treatment. But in order to address the main gap that we've seen in the literature so far, which is that most of the studies looking at predictive brain imaging have relied on open trials and not controlled treatment trials, we're now going to randomize folks to receive either CBT or SSRI medication. So that we can identify treatment specificity, that these neural markers we identify in the default mode network at pre-treatment may be able to distinguish between responders and non-responders to these two competing treatments. With oxytocin, we're interested in seeing whether it can enhance vicarious extinction in social anxiety. So people have put forth a general hypothesis that oxytocin plays a role in extinction learning in general. And that's based on a lot of basic research done on fear extinction, showing that oxytocin has a lot of receptors in limbic regions. It's expressed significantly in the amygdala, and there's been studies showing that oxytocin can facilitate extinction if it's given prior to extinction training. But here, the hypothesis that we have is a little bit different. We think that oxytocin's effects would really capitalize on social learning. And what that means is that if you can learn extinction vicariously through someone else's safety experience, you might actually get even more of a bump from receiving oxytocin than just traditional extinction learning. So our collaborators at the Karolinska Institute, Andreas Olsen and Armida Golkar, they tested the question of whether vicarious extinction can improve fear regulation and memory consolidation of fear, of social threat fear, compared to traditional extinction. And they found that it elicits the same neural connectivity as you would expect using traditional extinction, but that vicarious extinction does improve fear regulation. And so capitalizing on those findings, we propose to first see if vicarious extinction can help folks with social anxiety in the placebo condition. And if it does, we expect that if they were to receive oxytocin, that they would receive an additional boost in recalling safety or remembering that certain faces are associated actually with safety and not danger. So we're using their adapted vicarious extinction paradigm for this study. And this is a study that John is actually sponsoring that was just awarded by the Brain and Behavior Research Foundation. So hopefully I've shared some findings to show that advancing our understanding of who benefits from treatment requires really close attention to individual differences in pathophysiology, and that we need to exploit the heterogeneity of the clinical presentations that we see with our patients, and that there's many different ways people benefit from treatment, multiple treatment mechanisms that we need to account for. With oxytocin, it seems that in BDD at least, it may worsen other-oriented internal blame attributions in a way that you're not ready to implement oxytocin yet for clinical use. So the story here seems to be that oxytocin might only help certain individuals under certain conditions. There's also sex differences that we really didn't get into, but really becomes relevant when we're talking about fear extinction as well, since there seems to be some interactions between oxytocin and gonadal hormones and variation in oxytocin levels over the course of a woman's menstrual cycle. So many other things to sort out to understand oxytocin's effects. The translation to clinical practice really requires rigorous research design, so controlled treatment trials in the area of predictive brain imaging, but also standardized methods in acquisition and processing. A lot of different labs testing oxytocin started to just develop their own protocols for how to administer oxytocin, how to acquire oxytocin. There's multiple different ways to get either the commercially available drug or compounded drug. I've done it both ways, and they all have different formulations, but the research community needs to standardize some of these procedures in order to make some of these findings more reproducible, because that's probably the greatest critique of oxytocin research in humans, much less clinical populations, that the findings are not reproducible. So standardizing these these research decisions that every lab is doing is really important, and also really relevant for imaging as well, which is now leading to more efforts to standardize processing pipelines. So I will leave you on that note, and just wanted to thank all of the advisors, mentors, and collaborators I've had on various early career projects before coming to UW, and who still continue to mentor me. In particular, Sabina Wilhelm, Dara Minoak, Liz Lawson, Stefan Hoffman, who was my graduate advisor, and several K Award mentors, Jamie Fusner, Luan Fan, and Mark Vangel. And just to acknowledge my funding sources as well. Thank you so much.
Thank you, Dr. Fang, for walking us through this collection of studies in two different domains with some convergence in the questions as well. It's very informative. I'd like to encourage participants to write in questions that we could go through here in the remaining minutes. You could type it into the chat. I also put the chat for the evaluation link in there as well.
Did I stop the screen share, Joe?
Yes, that would be fine. Thank you. Now, just to start us off, while maybe others are writing in questions, I wonder about self-focused attention, Dr. Fang. Okay, here's a question that came in from Dr. Borgasani here. Is it known how SSRI affects the DMN and healthy controls? And how might this knowledge inform your studies?
Yeah, we had to look into that quite a bit, because we had several psychiatrists tell us that they didn't think that default mode network connectivity at baseline would necessarily predict non-response to SSRI treatment. And I think it's because SSRIs still require attention in order for you to benefit from the drug. But to answer your question in general, this isn't a really well-studied area. And the DMN is also a really, it could be really abstract, because there's so many actually components of the DMN that tap into slightly different processes. So the core system is what everyone knows about the DMN, that it's involved in internal cognition, but there's also a self subsystem and a memory subsystem that's involved in processing both past and future oriented memories, and also autobiographical information about the self, which also to some degree involves processing information about others. And so there's quite a bit of stuff involved in what the DMN mediates. So it's not well studied, but it's really important to look at that. I wonder, John, actually, if you have any thoughts on that, or.
If I ever want to know about DMN, I ask Paul. I was wondering though, quick question. Is there any role for quantitative EEG to be used? Will that report the right part of the brain to be helpful in making predictions in patients more economically, and maybe using things like machine learning to try to make estimations?
Yeah, there are people who are looking into that because the argument seems to be that it is a more scalable technology. But I would argue that the findings are even less stable than fMRI at this point. There's been a lot more people looking at task-activated data and resting state measures through MRI. I think the central commonality, regardless of which technology you use, is that if there can be some really tight correspondence that you see between the neural measures and some clinical or self-report measure, then you don't even need that measure to begin with. You can just use the self-report measure because it serves as some surrogate proxy, and that could be the most scalable because that's already integrated in our workflow. So I think a lot of folks are interested in that, especially in the digital therapeutics world. They're really interested in identifying surrogate markers that could be more precise in predicting behavior. So yeah.
Dr. Feng, a question came in regarding dimensionality. About the outward focused attention and self-focused attention. Are there unhealthy levels of outward focused attention? Is there a balance that's sort of maybe optimal or most healthy? Would you have a comment on that?
There probably is. And I would probably look into the ADHD literature for that, because it's not so much of an unhealthy level of outward focus, but an unhealthy level of too much switching between internal and external. And that's what I wonder if would be one parameter that would be particularly disrupted in ADHD. It's just, I don't study any externalizing disorder, so I don't really know that literature very well, but I would imagine there is a sweet spot in terms of the degree you want to be able to multitask and, switch your DMN on and off, but it can probably also go too far.
Now, another question. I'm wondering if you could comment on the self-focused attention. I was trying to understand. I think I was learning about the methods as presenting, and maybe I lost sight of the self-focused attention in general. Would you consider this more of a sort of a marker of symptom severity in a specific disorder, or maybe more of a concurrent clinical feature that might have one of many potential explanations?
I don't see this as a marker of severity, and that's because there are a lot of folks we had to turn away for this trial because they met criteria for social anxiety or BDD, but they didn't meet the cutoff. So it's just, if you think about the RDoC framework, for example, it's one way to just reshuffle these people into some other more meaningful categories that might have neural or genetic correlates. And so this is just one of many cognitive biases that have been studied in anxiety disorders. The most common one being attention bias to threat, which is usually measured using some sort of spatial cueing task or a dot-prod task, for example. But I see it as being just a cognitive bias that cuts across these disorders, but not necessarily a symptom or something that is a marker of severity.
That's very helpful. Thank you. And another question came in, Dr. Feng, which I think will be our final question, about your thoughts about possibly an ideal imaging study. Since it seems like there may be differences found on scanning and imaging studies frequently that find differences in brain structure activity, but sometimes don't hold up in cross-validation.
Yeah, so the R01 that we are waiting to hear back on actually proposes to use cross-validation using machine learning, using an out-of-sample test. And I think it's really going to help us refine predictions on the single subject level, because most of these studies, the other major flaw of the predictive imaging studies is that they're not testing for validation in and out of sample set. They're all kind of contaminated sets. There's been one study done by the other collaborator on R01 in OCD. And that's really important if you're thinking about prediction that's generalizable for the next person coming into the clinic. So the ideal study, you have thousands of subjects. You do cross-validation, external cross-validation. Yeah, those would be the characteristics of that study.
Well, thank you. And Dr. Feng, thank you for joining us for the Grand Rounds presentation today. There is one additional comment in the chat that I wanted to draw your attention to from Dr. Borghesani, perhaps as an opportunity to communicate down the road about these questions, as John pointed out. And thank you, Dr. Neumeier, for joining us and for introducing Dr. Feng today. And
thanks very much.
Thanks for having me.
That's great.
And take care.
Have a good day, everybody.
Bye.